Welcome to Expert Perspectives on Lymphoma Myeloma 2015, an international conference on hematologic malignancies. Today we had a session on lymphoma and Hodgkin's disease. I am Dr. Morton Coleman. I'm Director of the Center for Lymphoma and Myeloma, and I have with me today Dr. John Leonard, who heads up our lymphoma section at Cornell and was chair of today's session. John, welcome.
Thank you very much.
We heard some very exciting papers today, particularly with regard to basic science, and I think probably one of the most exciting aspects was that of checkpoint inhibitors. Would you tell us what your perspective is on this?
Sure. So we had two excellent talks today, one from Margaret Shipp and one from Steve Ansell, really focusing on the emerging role of the checkpoint inhibitors in lymphomas. We had discussion around the issue of, particularly in a Hodgkin lymphoma, that we have the malignant Reed-Sternberg cell that is really surrounded, really 90+% of the tumor mass is immune cells, and presumably those immune cells are trying to fight the lymphoma and are not doing a good job, and it appears that a component of that relates to the immune checkpoint issues. And those are, as the audience knows from various solid tumors, related to the idea that there are molecules expressed on both tumor cells and complementary molecules on immune cells that essentially dampen or downregulate the immune response against the tumor. And so the concept is to identify those lymphomas where those pathways are relevant and to then target a therapy toward that to ultimately lead to a more effective immune response against the tumor. And so because Hodgkin lymphoma is one of the lymphomas where that is more operative, we've seen activity, both nivolumab and pembrolizumab, that target the PD-1 associated pathways, and we see activity in Hodgkin lymphoma there. Certainly what Dr. Shipp alluded to was the fact that viral associated lymphomas, EBV and other viruses seem to play a role in T-cell exhaustion and upregulation of these pathways, and so it may be that those types of lymphomas are also relevant to this sort of therapy. And then we heard from Dr. Ansell about the fact that there are a number of other inhibitors and pathways related to immune checkpoints, as well as data looking at other lymphoma subtypes. And so I think this is a very exciting area. I think the challenge is going to be, where do we fit these therapies in amongst the armamentarium of lymphoma treatments, where we have lots, as you know, of effective treatments, effective combinations, chemotherapy, antibodies, and how are we going to combine them? Are we going to combine them, sequence them with chemotherapy and other approaches? Are we going to use combination checkpoint inhibitors? So there's a lot of work to do there, but I think certainly very exciting.
In regard to our being able to impact Hodgkin's disease, brentuximab vedotin now is being used rather widely. Where do you see brentuximab vedotin's role? Do you think it's merely going to be in treating patients who have relapsed or who have had bone marrow stem cell transplants? Or can you see brentuximab vedotin being brought up front, perhaps maybe even the checkpoint inhibitors being brought up front?
Sure, I think that's a great question, and you know, Hodgkin lymphoma, as you know, is highly curable, but we don't cure everyone, and so we have drugs that clearly are useful in the relapsed or refractory disease setting. Are we now going to use them, and the expense and to some degree the toxicity with respect to neuropathy, are we now going to use them in the upfront setting? And we have randomized trials, particularly in advanced stage Hodgkin lymphoma, adding brentuximab. We'll see what those show. We'll see the magnitude of the benefit and whether or not that benefit is a PFS benefit, an overall survival benefit, and you know where that fits with regard to the toxicity. It's, I think, pretty evident at this point that there is more toxicity when you do swap in for bleomycin brentuximab, and whether or not there's a payoff. Well, we'll just have to see. I think the other place where we're seeing them used now is as a consolidation or maintenance for essentially a year after auto transplant. We have clear progression-free survival benefits there. We don't have overall survival benefits, and so in my mind that remains a big issue, in that when patients can cross over if they progress and ultimately have the same overall survival, are you going to treat every patient who gets a transplant with the cost and the toxicity, or just use it in those that relapse when they need it. It's kind of like the rituximab maintenance question to some degree. If overall survival is the same, you might make an argument that just treat patients when they relapse when they need it.
One of my understanding of the studies is that they in fact did cross over, and it may have in fact impacted ability to see a difference in the overall survival. I think we can conclude that it didn't matter whether you got it early or late, it's helpful. And I understand also that in that study, it's the ones who are most likely to relapse who seem to have benefited the most. Do you think we'll have to go through some sort of patient selection in deciding who to give and how long to give it?
Yeah, I think we're still working on that. And as you know, prognostic issues in Hodgkin lymphoma, we have not been very successful in identifying a very bad group. I mean, the group of patients that has more risk factors still is a minority of patients. Those that were used in this study include short remission, extranodal disease, and those are things that still, while they are a riskier patient population, they're not the horrible patient population that they're going to do poorly and absolutely are compelled to add another drug. So I think there's a lot of work to do there.
Well, we're talking about prognosticating who is going to do well and who isn't going to do well. We heard some interesting data in follicular lymphoma where 80% of patients seem to do very well and follow almost the survival characteristics of a normal population. But it's 20% of these early relapses who seem to relapse within 2 years that do so poorly. Where do you think we're going to go with that?
I think those are the two main questions: is how do we approach those patients? And the good risk patients, as you allude to, those 80% of patients who likely are not going to die of follicular lymphoma, if you think about it, they're going to have, if they're going to live a normal lifespan largely, and they're going to have one way or another follicular lymphoma the whole time, then to some degree your choice of and sequence of therapies is solely based on quality of life. It's what's going to let that person live their normal lifespan while you control their disease with minimal toxicity and impact on their life. And so to some degree, the endpoints, the primary endpoints of studies really need to change. It shouldn't be PFS. It really should be what is going to make that person have a good life, albeit normal in its duration, presumably. On the other hand, as you mentioned, the 20% of patients who are going to do poorly, that's clearly the place where we're going to impact overall survival, and obviously, while numerically a smaller number, with lost life and morbidity and mortality, that's really the bigger problem. And so right now we can only identify those patients after they've progressed. I think we have a number of efforts to try to look at biomarkers. We heard from Randy Gascoigne about the FLIPI M7 trying to look at some molecular characteristics on top of the FLIPI clinical prognostic features to try to look at those patients early, try to identify them early, and then ultimately figure out what's wrong in those patients, what's different, and target therapies there. So we have, I would say, a baby step in that direction, but right now we haven't gotten very far as to prospectively pulling out those patients and doing something
While
different.
we're talking about the poor prognosis patients, what impact do you think novel agents or precision medicine may play for those 20%? More precisely, what do you think checkpoint inhibitors will do for these patients? So far, checkpoints haven't done as well with follicular because of other mechanisms, maybe surrounding cells. But also we have the IMiDs, and we now have signaling inhibitors. Do you think they'll impact that 20% in terms of their survival and so forth?
Well, I'm optimistic that they will, but honestly, we don't know. And in fact, in the cooperative groups we're planning, because the NCI has, I think, rightfully said, that's where the unmet need is, that's where you're going to impact the disease. Let's focus on ways to identify those people, and we're planning a study where we will biopsy those patients who have progressed early and take their and randomize them to one of several novel treatment approaches, generally not giving them chemotherapy, but randomizing them to options like IMiDs, PI3 kinase inhibitors, checkpoint inhibitors, and really other drugs that have rationale there. And the bottom line is that once we have those leads that we know in that group, one or more of these agents seems to work, and perhaps we have some leads on biomarkers, then we can take it up front and then design the next study, which will try to enrich for those patients to begin with and use that novel agent earlier in the course of the disease.
My biggest worry is we have so many studies, we may have more studies than patients. Now let's move over to aggressive lymphomas, particularly diffuse large cell lymphoma, which we know is more a heterogeneous disease than we ever imagined initially. And talking about ABC lymphomas or non-germinal center lymphomas and germinal center lymphomas. Where do you think you see our new approaches? Let's start off with EPOCH-R versus CHOP-R, the additions of proteasome inhibitors, the addition of IMiDs, the addition even of signaling inhibitors. Where do you see our going with the therapy of large cell lymphoma?
So there are two major issues there. One is obviously the fact that we do have groups that seem to have different prognoses, and we have lead targets, lead things to go after, and you've mentioned a number of them. The challenge in studying this, and I actually lectured on this just a little while ago, is that those groups were identified retrospectively in studies that took a population of patients, did a retrospective analysis of who had what profile and how did they do. It's a different story when prospectively you're identifying those patients and then doing a randomized trial within those subsets. And the reason, as you know, is that there's a huge amount of patient selection in those studies, in those prospective studies. And so what ends up happening is that when you start to do a prospective study in a poor risk group, and it takes some time to profile the patient, you end up losing some patients who are quite sick who can't wait, and the population gets better. And that's what we've seen. There was just published a study with bortezomib in randomized R-CHOP versus essentially R-CHOP bortezomib, swapping in bortezomib for vincristine in the ABC subtype or non-germinal center subtype, and that was just recently published in Blood, Ofner and colleagues. It turns out when you do that prospective study, both groups, it was in some ways a negative study, but the ABC subtype in this prospective study had an 80% cure rate. That's far higher than the original reports of the ABC subtype done retrospectively. And so the reason is that when you do it prospectively, getting the patient on the trial and getting them screened and so on, and the time involved, you lose bad patients. And we're at risk of losing a good drug that might help these patients because the study design is such that those patients, the patients that can benefit, don't make it onto the study for various practical reasons. That being said, I think we're going to have to continue to push forward with these approaches, and I'm optimistic that we'll get there with finding a subset where these drugs can benefit. But again, the trial design and doing it this way is going to be a major impact, and we're at risk of throwing out one or more of these drugs because of the nature of the trial.
Speaking about patients who need to go on treatment very quickly, let's talk about the bane of our existence in large cell lymphoma, which is the double and triple hit lymphomas, those lymphomas, large cell lymphomas that contain the MYC gene in either BCL6 or BCL2. Now, I understand that there's a difference between the germinal center lymphomas, where you actually see genetic changes, versus the non-germinal center, or ABC, if you will, who have expression of these gene products. How do you see? Where do you think we're going to go with these very difficult patients? They all seem to need treatment very rapidly, and they do very poorly. Do you see where we can make any impact on these diseases?
Well, I think as you correctly alluded to, there are two major categories. The germinal center subtype, which is typically better, but a subset of those that have the double hit by FISH at the genetic level. That is what we now are terming double hit. That group clearly does poorly. And we had some data from Adam Petrick, who presented one of the larger studies, suggesting that those patients do better with R-EPOCH, and so I think that's becoming a reasonable standard for those group of patients. And they don't seem to benefit from auto transplant. So they either get cured with the R-EPOCH, or if they relapse, they really do quite poorly. On the other hand, as you mentioned, the double protein expressors, those that don't have the FISH abnormalities, but express MYC protein, and more typically BCL2, but also BCL6, those are the group that tend to fall into the non-germinal center or ABC subtype. It's again a protein expression, not a genetic abnormality. those patients do a little better than the true double hit at the genetic level, but they're still less good or less favorable than those that don't have this double expressor phenotype. The double expressors, again, are in the non-germinal center subtype and probably account for much, if not all, of why that group tends to do less well than the germinal center type. And I think that, again, these are patients that tend to do less well. They're kind of an intermediately poor group. I think that the data that we have are largely supportive of giving our EPOCH, but I can tell you that if you go around and ask various experts, you'll have people giving our CHOP to those patients, people giving our EPOCH in the absence of a clinical trial, and others thinking that some of the non-germinal center drugs like we talked about, ibrutinib and lenalidomide, that may have activity are also things to think about. So we'll see what those randomized trials show, but it remains tough to have a clearly preferred standard today in the absence of a trial.
When I still look at the data for the double hits, even with EPOCH-R, the data are really rather dismal and very disappointing. Where do you think IMiDs and signal inhibitors will fit into our approach to large cell lymphoma? Do you think they may have a role, or I gather it's not very clear, but what do you think?
Right. Well, as you mentioned, in the double hit, I think one of the drugs that we're exploring in the cooperative groups and have a phase 1 and hopefully a phase 2-3 study will be using venetoclax, the BCL2 inhibitor. And since those double hit and double protein expressors have BCL2 activation, a BCL2 targeted drug certainly seems relevant there. I think in the outside of the double hit, in the ABC subtype, we do have preliminary data that again, ibrutinib and lenalidomide have activity as single agents in the relapse setting. I think that we'll see whether those randomized trials go. I think that it's either they're going to show benefit or not in combination with standard R-CHOP or R-EPOCH perhaps ultimately. On the other hand, if those randomized trials are not positive, then it's going to be more challenging to take them forward in the upfront setting, and they may be relegated to being kind of one of the things that we use in the relapse kind of palliative setting.
Yeah, in Hodgkin's disease, we heard some reports that we are tailoring therapy in those patients with limited Hodgkin's disease to try to get away from toxicity by using less therapy. How do you approach, based on some of the data which you heard here today, how do you approach your patients with limited stage Hodgkin's disease these days? Do you employ radiation? Do you not employ radiation? Do you do PET scans? If so, when do you do them? After the first cycle, the second cycle, or the third cycle? Just how do you approach your limited stage Hodgkin's patients?
So I think in limited stage disease, as the question really comes into how much ABVD do they get? Do they get radiation? And if they're not responding favorably, what more do you do beyond that, if anything? So we typically would get a PET scan after 2 cycles. I know you have often done it after 1 cycle. I think the results may be a little more useful in 1 cycle, but are largely, I would say, similar. And if the patient after 2 cycles is doing well and then essentially PET negative, then we would just give another 2 cycles most commonly and then call it a day. And that generally accounts for about 75% of people. The other 25% of people who are PET positive after 2 cycles, or who are PET positive still after their 4th cycle, I think that remains a challenge. And the issues there are really, do you give them radiation and call it a day? Do you give them switch to BIACOP? Do you give a combination of those? And to some degree, we have studies looking at those issues. There have been some data suggesting that the escalation to BIACOP may be valuable. Many of these patients, as you know, are young patients who are still concerned about those risks, although we have German data suggesting that that's manageable. I think to some degree it comes down to the devil being in the details. If it's a slightly positive PET scan versus a highly positive PET scan, as you well know, your inclination to do a little more, a little less, and the subtleties there may influence how aggressive you are in those cases.
Where do you see brentuximab vedotin going in patients who are untreated, not as a rescue drug, but as a drug up front? What do you think we're going to be doing with that? And tell us what's current as far as the use of BV in early stage or in disseminated disease who have not been previously treated?
Well, there's a large international trial that's looked at ABVD versus swapping in brentuximab for bleomycin. As you know, you can't give them together because of pulmonary toxicity. That's an advanced stage disease. If that's a positive trial, then I think either it will get used routinely there, or it comes down to the details of, is it a PFS without an overall survival benefit, how much of a difference is there, and what's the toxicity looking like. And the devil's going to be in the details of that and the impact of the difference. And if that's a positive trial in a substantial way, then I think we'll have to think about bringing this into the limited stage setting, although again, it really depends on the magnitude of the impact and the value of trading off perhaps using brentuximab to avoid radiation. And what's the trade-off there? What do you gain by adding brentuximab? What do you lose by the radiation? And is it a good trade-off? And I fear that in Hodgkin's, again, as you know, many of these situations are PFS benefits without overall survival benefits, just like radiation gives a PFS benefit without an overall survival benefit in a number of settings. And so then you're left with, what am I worried about? It's kind of pick your poison a little bit to some degree, and we may be in that sort of situation. If the advanced stage study is negative or really doesn't show a major benefit, then I think it's going to be hard to imagine that in the limited stage setting it's going to have an impact. And I think the next step is probably going to be to look at the checkpoint inhibitors and to see, to bring them up front and let them have their crack at it, so to speak, to see if they can take a shot at either improving chemotherapy or ultimately getting away with chemotherapy. I mean, it strikes me that the checkpoint inhibitor seems to be, as you know, brentuximab is really just a fancy way to give chemotherapy, whereas the checkpoint inhibitor seems to be more centrally targeting the disease biology and perhaps might have a better crack at the early point of things. But obviously, it's really hard to take away a treatment that cures 80 or 90% of patients, depending on the scenario, despite the fact that it is chemotherapy.
Well, John, we thank you very much for your expert perspectives on lymphoma, and certainly on the lymphoma section of Lymphoma Myeloma 2015. I am Morton Coleman, wishing you a good day.